Next speaker is Dr. Roshna Ahamed. Okay, again. Study of macular thickness in primary open angle glaucoma, ocular hypertension, and primary open angle glaucoma suspects as compared to normal eyes.
This is our study of macular thickness in primary open angle glaucoma, ocular hypertension, and primary open angle glaucoma suspects as compared to the normal eyes. So what is the importance of macular thickness in glaucoma? We all know glaucoma is a chronic optic neuropathy. There will be loss of retinal ganglion cell along with their axons in RNFL. So structural loss will occur only 5 to 6 years before the functional loss, and it is thought that 35 to 40 to 50% of RNFL is necessary for the alteration in the visual field to be detected. So retinal ganglion cells are located 30 to 35% in the macular area. So it is important. So why we had taken the central subfield macular thickness? Central subfield macular thickness is the average of all points in the inner circle 1 millimeter of radius in the OCT macular thickness map. So ganglion cell layer is thinning out into this area. So there are several studies which compare the total macular thickness. So in our study we are recording the central subfield macular thickness. It is to do a clinical study to compare the central macular thickness in eyes with POAG suspects and ocular hypertension and normal subjects. Objectives were to compare the central macular thickness in primary open POAG eyes and in normal eyes. Second is to correlate the central macular thickness with the severity of the glaucoma. Design, it was a prospective observational cross-sectional study. Site was a Contrast Charitable Eye Hospital at Calicut. Population was 64 detected POG patients and 64 normal patients. Time frame was from July 2018 to August 2019. We included patients of greater than 40 years and less than 70 years, diagnosed as POG suspects and ocular hypertension. And we excluded all myopic patients and all the patients with a history of diabetes and hypertension and eyes with significant ocular pathologies that bias the retinal macular thickness, such as diabetic retinopathy and ARMD, and eyes with acute angle closure glaucoma we excluded, and patient with the OCT macula couldn't be done, such as in hazy media we excluded. What we done was, first we recorded the patient and detailed history was taken, and ocular and systemic examination history was taken, and we done a best corrected visual acuity and slit lamp evaluation was done, and IT and gonioscopy was done, fundus examination done with 90D and indirect examination, and HFE test was done, and later OCT macula using Carl Zeiss Series SD-OCT model was done. What we got the result is that comparison of macular thickness in all glaucoma patients to normal patients, we found a statistical significant reduction in central macular thickness in glaucoma eyes while compared to the normal eyes. And we again compared the central macular thickness in POG eyes and normal eyes. We also got a significant reduction in central macular thickness in POG eyes. That is in agreement with the Greenfeld and Bagga et al. And Mafalda-Mota et al. We again analyzes the correlation of severity of POAG with the central macular thickness, and it showed a significant reduction of central macular thickness in severe POAG as compared to the mild and moderate. And we again compared the macular thickness in normalized suspects, and it showed a reduction in central macular thickness in suspect eyes as compared to the normal eyes. And we again compared with the ocular hypertension and normal eyes. It also showed a reduction in central macular thickness in ocular hypertension. So what we concluded is that there is significant reduction in central subfield macular thickness in eyes with glaucoma while compared with the normal eyes, and there is significant decrease in central subfield macular thickness with increase in severity of POAG, and there is significant decrease in subfield macular thickness compared to suspects and ocular hypertension patients. So overall from our study, it showed that central subfield macular thickness is a good tool for early detection of glaucoma, and it will help in the assessment of progression of glaucoma. So what was the limitation of our study? So it is a single center observation study, so results may bias, so it cannot be interpreted as a representation of the total population. So multi-center study is needed, and we use the SD-OCT Carl Zeiss Series OCT machine for the assessment of macular thickness. The newer SD-OCT, that is Heidelberg Spectralis, provides more clear details about the macular thickness. And a quadrant-wise macular thickness will be more a better indicator of the early glaucomatous damage. So we recommend a larger multi-center population-based study to establish our findings in this general population, and all glaucoma suspects, patients and ocular hypertension patients should be screened with macular thickness assessment for the early detection of disease, and we recommend macular thickness to assess the progression of disease. And the more research is needed in the management option to reduce the retinal ganglion cell loss. Thank you.
You just divide it into normal and all other together. Just confused.
Normal and glaucoma patients, and in glaucoma patients we divided into glaucoma POG patients, POG suspect patients and ocular hypertension patients.
Because your one slide shows only that POAG patients and normal, that is 64, and that's what I asked.
No, all patients were 64.
Yeah, that's together.
Together 64.
Did you exclude all myopes?
No, yeah, we excluded all myopes because in myopia there is changes in the OCT. So
all
we excluded.
POG also who had myopia you excluded?
Yeah, I excluded because in myopia there is changes in the, so the normal patients can be a problem. So
what else has been shown to be associated with a change in macular thickness? Actually, more than the refractive error definitely matters, but it's axial length.
Excellent. Okay, sir.
So one thing I would suggest is that axial length is a
Axial
confounder that you need to take into account.
Okay, sir.
The second thing is you have said that it is very good at differentiating, and you have shown us that the p-values are different.
Okay.
But when you are saying that it's good at differentiation, you have to tell us what the sensitivity and the specificity of this test is as compared to the gold standard.
Okay,
So you
sir.
should actually present sensitivity, specificity and area under the curve. And the third thing is your point number 3 in your conclusion is that it is useful to assess progression.
Okay.
You have not looked at progression.
Okay.
So when you have not looked at progression, it's not appropriate to make that statement.
Okay,
You
sir.
can say it may help in assessing progression, but you have not studied that.
Okay, sir.
So, I mean, these are, you already have the data for a lot of this, so you can probably just reanalyze some of it. But you already have the data, so you can actually reanalyze some of this.
Okay,
With the
sir.
exception of the axial length, the rest of it you can probably
Okay,
do.
sir. Okay,
Thank
sir.
you.
Thank you, sir.